Today we will discuss the National Health Policy 1983, 2002, 2017 and National Population Policy 1976 and 2000. I am Dr. Joshi, working as a professor, Symbiosis College of Nursing, and my specialty area is a community health. So today we will discuss the National Health Policy. You all know that India has got very long history and we are performing better in the aspect of the health. And it is because of the national health policy, which is established first time, it is established in 1983. And later on, it is go on revision many times. And now it is we have got a very robust national health policy and we have got a lot of uh, good points where there are various schemes for the poor people. There are healthcare delivery system is very systematic, scientific. We have got the three-tier system at the village level, and so forth. Our health matters are concerned with the Ministry of the Health and Family Welfare now at this moment, which is headed by the Union Minister, Dr. JP Nadda. This all is related to the national health policy. Okay, what do you mean by a policy? Policy is a system which provides the logical framework and the rationality of the decision making for the achievement of the intended objectives. See, every policy, rules, regulation, act, legal system, it all are related to the policy. Some document has to be created in which each and everything is mentioned in a disciplined way, in a systematic way. There might be the flow chart, there might be the logical framework, and for each and every decision, so there might be some justification or some what you can say the rationality. Understand? So that is the policy. What is meant by health? Health, it is already discussed many times in the past. And which is given by the World Health Organization. It is a state of complete physical, mental, and social well-being, and not merely an absence of disease or infirmity. So, see the health and policy. Understand? So, health is related to the policy. Means whatever the policies are established for purpose of the health is a health policy, and it is a nationwide applicable. It is not to the some part of the country and some part of the geographical area. It is applicable to all the peoples who are living in the nation. Understand? And it is a strategy for controlling and optimizing the social uses of its health knowledge and health source resources. So you all must be knowing that the 30th World Health Assembly in May 1977 resolved that the main social target of the government and WHO in coming decades should be the attainment of all citizens of the world by year 2080 and the level of health that will permit them to lead a socially and economically productive life. It is the first time after the independence that WHO has called the meeting for the by all the governments of the maybe more than 170 countries, and they have got only one agenda, that how the people in the world will enjoy all the optimization of the health by 2080. It was decided in 1977. And subsequently, this same agenda was discussed in the Alma-Ata Declaration, Alma-Ata Conference, which is happened in the Russia. At that time, it was the USSR. And the joint WHO and UNICEF International Conference in 1987 at Alma-Ata declared that the existing gross inequality in the status of the health of the people, particularly between developed and developing countries. So it was observed that there was a disparity in the health status of the people who are living in the developed countries and the developing countries. So within the countries of the politically, socially, economically unacceptable. So that is the health for all was the only one agenda for the declaration of this um, health for all. And so the establishment of the national health policy after the 1977, it was the discussed in the assembly. Then in 1978, it was discussed in the Alma-Ata Declaration in the conference. Then Alma-Ata Declaration called on our government to formulate a national health policies. It was discussed in that meeting only. Every country has to establish the national health policies according to their own circumstances to launch and sustain the primary health care as a part of the national health system. The Alma-Ata conference called acceptance of the WHO goal of health for all by 2080. See how many organizations and how many the government statutory organizations are taken part in that particular conference. That there was a WHO, there was a UNICEF, there was all the governments of the various countries, and they have decided health for all by 2080 and the primary health care as a way to achieve health for all. So primary healthcare concept has come into existence for the first time, and all the countries, all the registered countries has accepted the primary healthcare has to be there in each country and to achieve the health for all. And the reports of the working group on health for all by 2080 that's sponsored by the Ministry of Health and Family Welfare, Government of India. So that was the accepted by the Government of India, and we have established a appropriate system for the health for all. And this health policy forms a basis of national health policy formulated by Ministry of Health and Family Welfare, Government of India in 1983. So in 1983, the first national health policy came into existence in India, which is by the Ministry of Health and Family Welfare, Government of India. So what the National Health Policy in 1983 has said, the India has its first national health policy in 1983, that is 36 years after the independence. And in the circumstances then prevailing, this policy provide the initiative. What initiative they provide? The comprehensive healthcare linking with extension of a health education. See, healthcare linking, comprehensive healthcare linking. Healthcare linking means health organizations will not work independently. They will work along with the other disciplines like agriculture ministry, health ministry, education ministry, social welfare ministry. Each and everyone it is a 360-degree approach to the healthcare. It was the first circumstance for the national health policy. And health education. Health education is a foundation of all healthcare activities. Then there is an intermediation by the health volunteers. Intermediation by the health volunteers. Understand? There should be the whole health volunteers, which become a what you can say the coordinating person between the people and the health services. So that intermediation was the another concept which has developed in the national health policy. Then the decentralization to reduce burden of high level of referral system. Decentralization means all the facilities should be at the grassroots level. Understand? So for that purpose, we have a sub-center, we have a primary health center, we have a community health center, we have a rural health, we have a district hospital, we have a teaching hospital, we have a tertiary care hospital. So that much of chain they have created for the decentralization of the health system. And to make government facility limited to the eligible poor by private investment of the patient who can pay, and to make government facility limited to the eligible poor. So the health facility should be given free of cost to the poor and needy people. And private investment on or the private organization will serve the private patients, those who have got some financial power, so they can go for the private investment or private hospitals. Okay, so National Health Policy in 1983, what they have suggested the necessity of complete integration of all plans for human development with socio-economic development. Means it is not only the related to the health, but it is related to the human development as well as the socio-economic development. How the each and every person living in the country, they are sustained their own expenditure. They are independent. They should be economically independent, socially independent. They should have the free of autonomy. Health related sector like pharmaceuticals, agriculture, rural development, education, social welfare, housing, water supply, and conservation of environment were integrated for joint venture. Our health policy is not a isolation, working in isolation. It works in a close association with the all other department like education, social welfare, housing, water supply. National Health Policy 1983 stressed that the need for providing primary health care with special emphasis on prevention, promotion, and rehabilitation aspect. So it also covers, see how much is it is a interdisciplinary. Okay, it should be affordable to all the people. Understand? So it is for the poor, needy people, and the approach is the prevention, promotion, and rehabilitation aspect. It also emphasizes on the team approach, ban on the private practice by health professionals, and use of our large stock of health manpower from alternative system of medicine like Ayurveda, Unani, Siddha, homeopathy, yoga, and naturopathy. So this entire system is, again, another concept is the alternative system of medicine. Means it is a, what you can say, the 360-degree healthcare services, or you can say the holistic healthcare. Holistic, it means it includes Ayurveda, it includes Unani, Siddha, homeopathy, yoga, naturopathy, along with the modern medicine. Along with the modern medicine. The modern medicine cannot be neglected because in case of emergencies, in case of the urgency of the health, so the modern healthcare system is come into the existence. But for the prevention and for the promotion of the health, so probably the Ayurveda, Unani, Siddha, homeopathy will be more powerful. It is also suggested plan time-bound attention to the following. So nutrition, what are the things included in the national health policy? Nutrition, prevention of food adulteration, maintenance of good quality of drugs, water supply and sanitation, environmental protection, immunization, maternal child health services, school health program, and occupational health programs. Means, see, it is not related to the only the health. See, whatever the determinants of health, whatever the dimensions of health, all has to be covered, like nutrition, drugs, medicine, sanitation, environment, immunization, maternal and child services. These are very important component of the national health policy. So that is also one of the uh, good component. It is also suggested that the need for meeting a national requirement of life-saving drugs and vaccines by quality control. Okay, so because see, the modern medicine relies on the drugs and vaccines, understand, and which are very important in regards to the even the prevention of some of the diseases and for the treatment purpose. Understand? So that is also important thing in the national health policy and well considered health insurance schemes to allow community to share the cost of the services and keeping with the paying capacity. So it is that particular health system should be affordable to the people. The cost of the services should be very minimal so that every person, every poor person, every needy person can take the medical treatment. At the end of 2000th century, it was clear that the goals for health for all by 2080 would not be achieved. The observed progress suggested that we may need some new and additional strategy for the new sizable intervention in achievement of the unacceptable health of the country. So what happened after 2000? After 2000, see, it was decided that health for all by 2080 means each and every person of the country should able to approach the health care services to their nearby. But by the end of 2080, which was not achieved. So government has decided to have some additional strategy for new sizable intervention in achievement of an unacceptable health of the country. And the factors responsible for this failure were biased and poor socioeconomic development in the region where it was needed most. Means where it is needed most, there the services was not there. Where there is a maybe particularly in the urban areas, nearby urban areas or peri-urban area, there are lot of health services. But in the hilly area, difficult area, tribal area, there was no health services. So that was the observation of the 1983 policy. And there was a discriminatory policy due to age, gender, and ethnicity, thus preventing access to the healthcare surveillance. So that was again one of the thing which was very important. Discriminatory policy due to age, gender, and ethnicity. That also is an observation of this policy. So that was also observed, and next in the next thing, it was inculcated all these points. So then the National Health Policy 2002. So what happened in the 1983? We have said there are lacunae. There was some lapses. So it was not accessible. It was not affordable. It was not approachable. It was not all components are included. So the NHP 1983, there was a significant changes in the determinant factor related to health, which required a revision of the policy, and new national health policy came into 2002. Understand? And according to this revised policy, government and health professionals are obligated to render good health care to the society. So the good healthcare society means here the emphasis is given on the good health, means good quality, optimizing the use of health services. Optimizing the use of health services means again it is a accessible to a larger group rather than the small group is foreseen event by the 2002. The inclusion of social policies adds to the credit of the revised National Health Policy 2002. Inclusion of the social policies. National Health Policy 2002 has set out the new policy framework for the acceleration of the public health goals in socio-economic circumstances currently prevailing in the country. It has set new policy framework for acceleration of the public health goals. Understand, in the socio-economic circumstances currently prevailing in the country. Okay, so that was the new policy. It is acceleration of public health goals. Means health goals are, it is little bit aggressive policy. National Health Policy 2002 is a aggressive policy. Means it is an acceleration. Everywhere it is a speed should be increased. Then the objectives of that National Health Policy 2002 are achieving an acceptable standard of good health of Indian population, quality, decentralizing public health system by upgrading infrastructure in the existing institution. Means existing institution, there is upgradation, there is expansion of the primary health care, expansion of the sub-centers, expansion of the community health centers, ensuring more equitable access to the health services, more equitable access to health services across the social and geographical expanse of India. Okay, equitable access to health services across the social and the geographical expanse of India. Then the enhancement, the contribution of private sector in providing health service to the people who can afford to pay. enhancement of the contribution of private sector. Understand? So contribution of the private sector is substantial because at this moment, at the 2002, only 10 to 15% government services are utilized by the people. Means 10 to 15% of the people utilizing the government services. Now in the 2002, they have increased up to 25%, emphasizing the rational use of drugs. Drugs should be less and prevention should be more, increasing access to the triad system of traditional medicine. Traditional medicine are the included in the National Health Policy 2002. Then the goals to be achieved by the 2000 to 2015, because here they have set some targets, task and targets was set in the 2002 policy. Enactment of the legislation for regulating minimum standard in the clinical establishment and medical institutions, 2005. Enactment of the legislation for regulating minimum standard, eradication of polio and yaws. Understand, eradication of polio and yaws. These are the type of fevers, so which are very dreaded because polio, it is uncurable. So that was the eradication was included. Elimination of the leprosy. Leprosy should be eliminated entirely. Increase the state sector health spending from 5.5 to 7% of the budget. Understands? Health sector spending, health sector expenditure should be increased from 5.5 to 7% of the budget. Then establishment of an integrated system of surveillance. National health accounts and health statistics. Health statistics should come. That is, vital statistics has to be their integrated system of surveillance, means all the components should be included in the surveillance. 1% of the total budget for the medical research. Medical research, 1% of the budget. Decentralization of implementation of the public health program. Decentralization, because we have to reach to the grassroots level. Understand? To the villages, to the cities, to the towns, we have to reach. And that is the that is very important because we have a national health programs, and that national health program should reach to the last person of the country. Achieve zero level growth of HIV/AIDS by 2010. By 2010, HIV/AIDS should reach to the zero level. Means there should not be any increase in the HIV/AIDS patients. Then goals to be achieved by 2000 to 2015. Elimination of the Kala-Azar, reduction of the mortality by 50% of an account of tuberculosis. Tuberculosis should decrease by 50%. Malaria, other health sectors. So that is reduce prevalence of the blindness to 0.5%. Reduce prevalence of the blindness to the 0.5%. Means half. We should reach to the only half. Understand? Reduction of the infant mortality rate to 30 to 1000 live birth and MMR to 100 per lakh live births. So that is the big target which was set in the 2002 policy. Increase the utilization of public health facilities. Public health facilities, whatever the public health facilities are there, increase from 20% to 75%. Though it is a very difficult task, but now it has reached to the at almost 30 to 35%. Increase the health expenditure by government from existing 0.9% to 2% of the GDP. Increase health expenditure should be increased to the 2% of the GDP. Increase the share of central grants to constitute at least 25% of the total health spending. Central grants should be 25% of the total health spending. Further increase of the state sector health spending from 7% to 8%. Increase of the health sector spending to 7 to 8%. and 2% of the total health budget of the medical research 2015. It is increased. Earlier it was 1%. Here it is at 2%. And elimination of the lymphatic filariasis. Lymphatic filariasis disease is very dreaded disease. So that has to be eliminated. In spite of all good things in policy, it is also suffers some criticism which are as follows. Women's has not received enough attention in the policy. So what are the lapses of the 2002? First lapse is the women's health was not received enough attention. Similarly, child health, adolescent health, gender discrimination, violence should have received adequate concern. So even that also not taken care properly. This policy did not refer to the Women Empowerment Policy 2001 while describing the measures to ensure women's health. So this policy did not refer to the Women Empowerment Policy. Old age group has got very less attention in the policy. Means women are not covered well. Women's empowerment was not covered. Old age groups is not covered. Life expectancy has crossed 60 years of age and going to be 70 in the decade, which demands special health services for this group and cannot be neglected the next. Understand? Cannot be neglected. Occupational and environmental health should have been addressed properly as far as standards, safety measures, and recreational facilities is concerned. Understand? Occupational and environmental health. That is most important thing. Then the school health program have not achieved a desired result in the majority of the states. School health programs. The program have become almost a defense because of the administrative, managerial, and logistic. School health program was not yet achieved a good result because it is not in the measurable term. The school health program or occupational health program or whatever the health policies, it was not a measurable term. So when it becomes a measurable term, at that time, the program will get some acceleration. Then comes based on the lapses which have happened in the 2002 policy, then the National Health Policy 2017 came into existence. The National Health Policy generally described the fundamental principle regarding which health providers are expected to make value decisions. The fundamental principles remain same. Fundamental principles described in that policy, and only the value decisions are added into that. It provides the broad framework of the decision for guiding health actions that are useful in the community in improving their health, reducing the gap between health status, and have the quality of life. Quality of life has given more importance in the National Health Policy 17. Fundamental principles remain same. Value added program. It is a broad framework of the decision. Quality of life. Primary aim of the National Health Policy is to inform, clarify, strengthen, and prioritize the role of the government in shaping the health system in all its dimensions. It is very robust policy. It is very elaborative policy. It is clarify, strengthen the role of government. National Health Policy 1983 and the National Health Policy 2002 have served well in guiding approach to the health sector in 5-year plan. Now, 14 years after the last health policy, new policy is introduced to improve health status of the people. So need for the new health policy, why it is needed? The health priorities are changing. There is a growing burden on account of non-communicable disease and some infectious disease emerge. The robust healthcare industry estimated to be growing at double-digit healthcare cost increasing, which are presently estimated to be one of the major contributors to the poverty. See, what happened? The health priorities are changing. The people are becoming the very educative, sensitive. Then the law also protects the consumers. Non-communicable diseases are increasing, infectious diseases are increasing, and the growing healthcare industry growing. Understand? So that is the major contributor to the poverty. Rising economic growth enables enhanced fiscal capacity. Therefore, new health policy responsive to these contractual changes in the contextual changes is required. So why there is a need? Because health priorities are changing. There is a growing burden of account of non-communicable disease. Rising economic growth. Economic growth is increasing because our growth rate was 2-digit. Growing incidence of catastrophic expenditure due to the healthcare costs, which are presently estimated to be one of the major contributors to the poverty, because healthcare cost is increasing. Every investigation is increasing. Every drug is costly. And emergence of the robust healthcare industry estimated to grow at double-digit. And the objective of this policy is health status through the concerted policy action in all sectors of expanded preventive, promotive, curative, palliative, rehabilitative services provided to the public health sector. So now the horizon also is increased. Horizon has gone beyond only the preventive, promotive, and curative. It has promotive, preventive, curative, palliative, and rehabilitative services. Understand? Then the creation of public health management cadre in all states. That is most important. Creation of the cadres. Intervention from early detection of the disease in the childhood to the prevention of chronic illnesses. Tracking behavior change, education. Plethora of the options to choose from among yoga, Ayush umbrella of the remedies. So this is the wide horizon of the National Health Policy 2017. Okay. And the principles of the policy, the professionalism, integrity, and ethics. It is the highest level of professional standard has to be maintained in the policy. There should be integrity and ethics to be maintained in each healthcare system. There should not be any violation of the rules and regulations of the government. There should be a strict protocol for the medical treatment. Understand, supported by credible, transparent, and responsible regulatory environment. So that is included in this policy. Then equity. Equity is reducing inequality. Inequity would mean affirmative actions to reach the poorest. It would mean optimizing disparity on account of the gender, poverty, caste, disability, other forms of social exclusion, and geographical barrier. It would imply greater investment and financial protection for the poor who suffer the largest burden of the disease. So it should be equally distributed. Understand? So there is a gender, poverty, caste, disability. It should be unbiased. Affordability, cost of care increases. Affordability as a distinct from equity requires emphasis catastrophic household healthcare expenditure exceeding to 10% of its total monthly consumption expenditure or 4% of the monthly food consumption expenditure are unacceptable. So these are all equity, affordability, and integrity, high professional standards. These are the principles of this policy. Universality. Universality is exclusion on the social, economic, and grounds of the current health status. So there should not be any social bias, economic bias, current health status bias. In the backdrop system, services are envisaged to be designed to cater to the entire population, including social groups. Patient-centered quality of care, gender-sensitive, effective, safe, and convenient healthcare services to be provided. There is need to evolve the disseminate standard and guideline for all levels of facilities. Means all the level of facilities to all the people to the without any discrimination. Accountability, financial and performance accountability, transparency in decision making should be followed. Then the multi-stakeholder approach with the partnership, multi-stakeholder approach, inclusive partnership, participation of all health ministries and communities. This approach would include partnership with academic institution, not-for-profit agencies and healthcare industry. Means it's not only healthcare industry, including the teaching hospitals, teaching centers, teaching institutions, non-profit agencies, NGOs, that all should be included in the healthcare services of the people. Pluralism, that is patient who choose the when appropriate would have access to the Ayush care programs. Means they should have got the autonomy to choose the which type of treatment they require. whether they require the modern medicine, whether they require Ayurveda, yoga, Siddha system, whatever it is, they are given the autonomy. Decentralization should be there. That decentralization of decision making to level as is consistent with the practical consideration and institutional capacity. Community participation in health planning process to be promoted side by side. So that is decentralization. Then the dynamism and adaptiveness, constantly improving the dynamic organization of healthcare based on the new knowledge and evidences with learning from the communities and from national and international knowledge partners is designed. So there is a dynamism and adaptiveness. And so indicative goals and objectives are outlined under three broad components. So again, the goals and objectives are outlined under the broad objectives is health status and program impact. What is the health status of the people and what is the program impact? Then the health system performance, how the health system is performing and health system strengthening. So these are the three major component or major principles of the policy. So health status, how the health status is measured. So it in regards to the life expectancy and healthy life. Okay. Another is the increased life expectancy at birth from 67.5 to 70 by 2025. So life expectancy should be, it is all in the measurable term. Establish regular tracking of disability adjusted life years index as the measure to burden of disease, and it's a trained by the major categories by 2022. So it is a disability adjusted life years. Reduction of the total fertility rate to 2.1 at national and subnational level. So a reduction of the fertility rate means, so on an average, every couple should give the birth to the 2.1 child. Understand? So it is in the statistical term. Mortality by age and cause. Mortality should be reduced. Reduce under 5 mortality to 23 by 2025 and MMR to 100 by 2020. Reduce infant mortality rate by 2028 by 2019 and reduce neonatal mortality rate to 60. So these all health status are measured with the what you can say the vital statistics. These are the vital statistics. Okay. Then the reduction of disease prevalence and incidence. So we have to reduce the global target of 2020, which is also termed as target of 90-90-90 for HIV/AIDS. 90% of all people living with HIV know their HIV status. 90% of all people diagnosed with HIV infection receive sustained retroviral therapies, and 90% of all people receiving antiretroviral therapy will have the viral suppression. So these are the 90-90-90 strategy has to be implemented in the 2020. And to achieve and maintain the elimination status of the leprosy by 2018, Kala Azar by 2017, and lymphatic filariasis in India be broken by 2017. So that is the achievement has to be there. Then to achieve and maintain the cure rate of more than 85% in the new sputum positive patient for the TB and reduce incidence of the new cases to reach elimination status by 2025 and to reduce premature mortality from cardiovascular disease, cancer, diabetes, or chronic respiratory diseases by 25% by the 2025. So that is the premature mortality rate should be reduced. Then the next component is the health system performance. Now we have seen the health status of the people in terms of the statistics. Now the health system performance means how the health system should be. It cover health services, coverage of health services, increased utilization of public health facility by 50% from the current level by 2025. Means the people are not using the health services, public health services. So that has to be increased. Antenatal care coverage to be sustained about 90% and skill attendance at birth about 90%. Antenatal care coverage to be sustained about 90%, means 90% of the antenatal mother should come to the institutional follow-up. Skill attendance at birth means institutional deliveries by 90%. More than 90% of the newborn care fully immunized by 1 year of age by 2025. More than 90% of the newborn care fully immunized. Meet the need of family planning above 90% at national and subnational level. 80% of the known hypertensive and diabetic individual at household level maintain controlled disease status by 2025. So that is then the cross-sectoral goals related to the health. Now, the third component is the cross-sectoral goals, means all the sectors should be included in the health services, included in the healthcare. Reduction in the prevalence of the current tobacco use by 15%, 2020 and 30% by 2025 means reduction in the current tobacco use, reduction of 40% in prevalence of the stunting of the under 5 children by 2025, because there are lot of under 5 children are stunted growth. So that has to be increased. Access to safe water and sanitation by 2020, Swachh Bharat Mission. Then the reduction of the occupational injury by half from the current level to 2020. How we can do the health system strengthening? Okay, so first component of the health system strengthening is health finance. So health finance, our GDP increase the health expenditure by government as percentage of GDP from 1.15 to 2.5% by 2025. Means from the GDP is 2.5%. Means imagine how much is the total quantum which is important in the healthcare expenditure. Increase state sector health spending more than 8% of their budget by 2020. Decrease in the proportion of the household facing catastrophic health expenditure from current level by 25% by 2025. Health infrastructure and human resource. Health infrastructure should be increased, human resource should be increased, ensure availability of the paramedics and doctors as per Indian public health standard in high priority district by 2020. Increase the community health volunteers to population ratio as per the IPHS norms in high priority district by 2025. Establish primary and secondary care facility as per the norms in high priority district by 2025. Then the health management information. So ensure district level electronic database of information or health system component by 2020. Strengthen the health surveillance system and establish registries for diseases of public health importance by 2020. And establish the federal integrated health information architecture, health information exchange and national health information network by 2025. So this is the health management. Means they are not putting only in the burden on the one sector. It is health status of the people, health services of the people. There are the task and targets. There is a health management information system. Means all the component. It is integrative, multidisciplinary, multifactorial approach should be there. Okay. Then comes to the national population policy. Okay. Now in the health policy, we have seen that whatever how the 1983 policy is established with the reference to the Alma-Ata Declaration. Then later on, 2002 policy revised, and again 2017 policy revised. And in 2017 policy revised, which includes all the sectors, which includes the health expenditure. Then a lot of infrastructure has to be developed. A lot of health manpower has to be developed. So that was all included in the National Health Policy 2017. Then the National Population Policy 2000. So the population means it is a summation of all organisms of the same group or the species which live in the same geographical area and have capability of the interbreeding. So population is the population. It is the number of the people living in that particular geographical area or in that particular state, country, district, whatever it is, with the same group of species. Okay. Then what is the policy? Set of ideas, plans used by the basis for the decision making, and it is attitude and actions of the organization regarding the particular issue. General statement of the understanding which guide decision making. This policy intended to decrease the birth rate and growth rate. Understand? So the policy is focused towards the decrease in the birth rate, okay, and improve the quality of life. And the need for the national population policy was felt in 1970s. It was drafted in 76. Policy statement on the family welfare program was also prepared in 1977. Both of these statements were tabled in the parliament but were never discussed or adopted. See, this policy is again, it is in align with the National Health Policy 1983, emphasized the need for securing the small family norm through the voluntary efforts and moving toward the goal of the population stabilization. The important features of the National Population Policy 1976 are increase the age of marriage from 15 to 18 for girls and from 18 to 21 years for boys, because it was observed that there are millions of the children born to the women from the age of the 15 to 18. If this is increased, then legal age of the marriage for the women will become 18, and for the boys it will become 21. So there is a tremendous substantial control of the birth rate. Freeze the population figure at 1971 level until 2001. Freeze the population figure. So whatever the population figure is there and at the 71 should remain in the 2001. Make some portion of the central assistance provided to the state dependent upon their performance in the family planning. So there should be some incentives. There should be some benefits for the people who are maintaining the small family norms. Give greater attention to the education to the girls. In the right from the beginning, in the government policies as there. So there is a attention to the education to the girl. Ensure the proper place for a population education in the total system of education. Even in the curriculum, in the general curriculum, it has to be included the population education. So that will help the people and help the small children to get some knowledge regarding how the population is expanding or how to control the births and etc. Involve all ministries and department of the government in the family planning program. Ministry, department of the government in the family planning program. This family planning program should be part and parcel of the entire development system in the education, in agriculture, in the health, in other sectors, in the developmental sectors. So that has to be supported. Increase the monetary compensation for sterilization. Sterilization is one of the important component. So that monetary compensation should be given. The Institute Group awards as the incentive for the various organizations and bodies representing the people at the local level. So the Institute Group award incentive for various organizations and bodies representing the people at local level, including Jilla Parishad and Panchayat Samiti. So those who are supporting this mission of controlling birth or population control, so they all should be given awards or the incentives, including the government sector like Jilla Parishad, there is a Panchayat Samiti, primary health care, sub-center, even the local people. So it is very important. Then encourage the intimate association of the voluntary organization, particularly those representing women, with the implementation of the program. So intimate association of the voluntary organization. Voluntary organization also, we have to just see that particularly those representing women and implementation of the program. Impart more importance to the research activities in the field of population control. More importance of the research activities in the field of population control. So research activity has to be increased. Use of mass media for motivation, particularly in the rural areas, or to decrease the acceptance of the family planning methods. So that has to be there. So use of mass media for motivation, for propaganda, particularly in the rural areas, all the media should be covered like radios, television, or the social media, etc. So National Population Policy established in 2000. In 1988, draft for the National Population Policy was finalized. After the consultation, it was approved by the cabinet and was examined by the group of ministers. And the draft was discussed in the cabinet on the 19th November 1999. And the suggestions were incorporated and the final draft of the National Population Policy was placed before the parliament and it was adopted by the government from 15th of February 2000. So in this way, from 1998, it took 2002 years for the drafting of the population policy, revision of the policy, and approval of the policy by the government. And the objectives of this policy are to address the unmet needs of the contraception, healthcare infrastructure, and health personnel. Okay, so that is the main objectives or main goal of this policy. Okay, so it is to meet the needs of the contraception, healthcare infrastructure, and health personnel, to provide integrated services and basic reproductive and child health care. Okay, the medium-term objective is to bring the total fertility rate to replacement level by 2010 and through the vigorous implementation of intersectoral operational strategies. So that is the medium objectives, and long-term objective is to achieve stable population by 2045 at the level of consistent with the requirement of the sustainable socioeconomic growth and development and environmental protection. So that is the long-term objective. So national socio-demographic goals for 2010. So address the unmet needs of the basic reproduction and child health services, supplies and infrastructure. Make school education up to age of 14 free and compulsory, and reduce the dropout of the primary and secondary schools level below 20% for both the girls and boys. So that is the basic agenda for this policy, and which helps indirectly in the control of the population. Reduce infant mortality rate below 30 by per 1,000 live birth, and to reduce mortality rate by 100 per 10,000 live birth. 1 lakh live birth, not 10,000. Achieve universal immunization of the children against all vaccine preventable diseases. Achieve the universal immunization of the children. Promote delayed marriage for the girls, not earlier than age 18 and preferably after the 20 years of age. Promote delayed marriage of girls. So if suppose the marriage of the girls will be delayed, then probably the total fertility rate will come down and it will help in the control of the population. Achieve 80% institutional deliveries and 100% deliveries by the trained person. So at least 80% delivery should be institutional deliveries and 100% deliveries by the trained person, or what you can say the SBA, that is by the trained birth attendants. And achieve universal access to information, counseling services, and fertility regulation and contraception with the basket of the choice. Understand? So this is one of the most important component in the control of the birth, which is the counseling services and fertility regulation and contraception of their choice, of the couple's choice. So achieve 100% registration of the birth, death, marriage, and pregnancy. All should be notified to the government so that it will help in the monitoring the statistics, contain the spread of AIDS and promote greater integration between the management of reproductive infection and sexually transmitted diseases and the National AIDS Control Organization. So that is one of the important component of the population policy. Prevent and control of the communicable diseases, integrate Indian system of medicine in the provision of reproductive and child health services and reaching out to the levels of total fertility rate. So again, Indian system of medicine means the approach is very comprehensive, approach is very integrative, comprehensive, so that the people will trust on that particular policy. Promote vigorously the small family norm to achieve replacement levels of the total fertility rate. Promote vigorously the small family norms to achieve the replacement level of the total fertility rate. So this is the one of the best component in the control of the birth or in the supportive to the population policy. So small family norm, because there are a lot of propaganda was occurred during this time. Understand? So when the population policy was established, so in the rural areas, in the remote areas, in the sub-centers, everywhere the government has taken very exhaustive steps for the small family norms. And because of that, now the population becomes the controlled population. And another thing is to bring out the convergence of implementation of related social sector programs so that family welfare becomes people-centered program. Family welfare program. The family planning program was converted into the family welfare program. Family welfare program, which includes everybody's health, right from the birth to the death, even the old age care also is included in the family welfare program. And what are the themes which was adopted? It is a decentralized planning and the program implementation. Decentralized planning. Always, even right from the 2002 policy, it is government is saying that it is a decentralized approach. Means whatever the activities are carried out in the district level or the teaching hospital level, the same activity should be carried out to the sub-center level. That is a decentralized planning program. Family planning program is a decentralized because even at the sub-center level, the family planning services are available. So that is most important thing. And the convergence of the service delivery at village level. Convergence of service delivery means all the services at the village level. Empowering women for improved health and nutrition. Every woman, even the rural woman, see, through the Anganwadi workers, through the Asha workers, every woman should be improved health and nutrition. Nutrition education should be given. Health education should be part and parcel of all activities which are conducted in the sub-center, rural health center, Anganwadi centers, whatever it is. Child survival and child health. Child health should be given more importance. Understand? Through the Anganwadi workers, to the Asha workers, to the primary health centers, the doorstep services has to be given to the maternal and child health. Meeting the unmet needs of family welfare services. Whatever the needed for the family welfare services, that has to be given by the health manpower. Underserved population group. Underserved population group. See, still now there is the dearth of the health services at the tribal level or in the rural level. People has to walk lot of distance to reach to the health services. There are no roads, there are no infrastructure. So that also population has to be covered by the health services. Urban slum. In the urban slum also the situation is very different because they don't have the money to spend on the healthcare services. So there also we have to give even the some of the urban center or urban health centers are established like primary health center, even the primary health center in the urban area. Tribal communities, hill area population and displaced and migrant population are covered under the health services. Adolescent services are included. Increased participation of men in the planned parenthood. Even the men is also included in the antenatal care services. So that is also one of the important things. Then diverse healthcare providers, collaboration with the commitment from non-government organization and private sector. Is collaboration. See, it is not only the government service. It is not only the government that have to look after the health services of the people. So it has to be private partners. It has to be the non-governmental organization. Not only the voluntary agencies. All should be given the whatever the task and they will complete the health services. Mainstreaming an Indian system of medicine and homeopathy. Indian system of medicine, Ayush. Ayush established in 2005, Ayush established, and it is a part of the our healthcare delivery system in India, providing the for the older population. Older population is increasing as lifespan is increased. Now the older people they are helpless, they are dependent. So their health services is also a very important thing. So information, education, and communication, IEC activities. So government has to establish some of the publication department. So that they will create a health information material, health education material, and it has to be communicated through the print media, social media, multimedia. All the media should be covered for this IEC activities. Then the promotional and motivational measures. Promotional measures in order to achieve the objectives and goals of the national population policy. Following promotional and motivational measures are enumerated. That Panchayat and Jilla Parishad. See, already Indian government has already established a Panchayati Raj system. It is a three-tier system where the district level, block level, and village level, there are various manpower, various health services are already working. And so these Panchayati and Jilla Parishad will be rewarded and honored for the exemplary performance in unverbalizing the small family norm, achieving the reduction in infant mortality rate, birth rate, and promoting literacy under the primary health center. So Panchayat and Panchayati Raj system and Jilla Parishad system has to be strengthened to give the information to the rural people regarding small family norm, infant mortality rate, so the care of the child. In the sense, so that all has to be inculcated in the population policy. Then there are some of the schemes like Balika Samruddhi Yojana, run by the Department of Women and Child Development to promote survival and care of the girl child. Understand? So it is a Balika Samruddhi Yojana. It is health of the girl child to continue cash incentive of rupees 500 awarded at birth of the girls of the order 1 or 2. So if your girl childs are 1 or 2, then the incentive is given rupees 500 for their health and nutrition. Then there is a maternity benefit scheme run by the Department of Rural Development will continue. Cash incentives of 500 is awarded to the mother who have their first child after 19 years of age and for birth of the first and second child only. So that is the maternity benefit. Then the family welfare linked to the health insurance plan. So it will be established couple below poverty line who undergo sterilization with not more than 2 living children would become eligible for health insurance, not exceeding rupees 5,000 and personal accident insurance cover for the spouse undergoing sterilization. So that is another health insurance scheme. Then the couples below the poverty line who marry after the legal age of marriage, register the marriage, have their first child after the mother reaches 21, accept the family norm, and adopt the terminal method after the birth of second child will be rewarded. So they will be given incentives. They will be given some services, free services. Even some of the mothers are given the transportation services, ambulance services are provided for the delivery. Understand? So, and all this delivery expenditure is the free of cost. There is no cost to the mother or that family. And in that way, it is incentives and the help and support is given. Okay. Then the revolving fund will be set up for the income generation activities by village level self-help group who provide community level. It is a women empowerment activity. So it is a self-help group has to be created by the village level self-help groups, and they help each other in the community health activities and the income generation activities. Crushes for the child care center will be opened in the rural areas and urban slums. This facility to promote participation of men in the paid employment. Because what happens, the women are not working because they are the small children in the home, and the creche services will be provided. Then women can be free to work outside of the home and they can earn some money. Then wider and affordable choice of contraceptive will be made accessible at the diverse delivery point. There should be some of the delivery points for the contraceptives. Each and every health services, even the Anganwadi offices or the Asha workers, they should provide the contraceptive to the women and the couples. Understand? Then there should be a facility for the safe abortion. Safe abortion facility should be given. So if suppose if the unwanted child is there, so and if the spacing is not proper, and in the legal framework, as per the whatever the government norms are there within the certain week of pregnancy, if that couple is willingly wanted to abort the child, so then as per the government policy, it will be done. The products and services will be made affordable through the innovative social marketing schemes. So social marketing schemes, because there are a lot of platforms are created by the government for the self-help group or the some of the what you can say the small saving schemes and all. Okay. Then the local entrepreneur at the village level will be provided soft loans and encouraged to run ambulance services to supplement the existing arrangement for the referral transportation. Okay, so if suppose the local entrepreneurs is there, some people are preparing something, some food material in the house, and they're packing properly, then government is providing some loans for them. Increased vocational training schemes for the girls. Vocational training for the girls. So like sewing machines or stitching or some small crafts. So these the girls has got a very high skill value. So they can be trained in the some of the skills leading to self-employment, and it will be encouraged. Strict enforcement of the Child Marriage Restraint Act 1976. So child marriage should not be there. So if suppose if anybody is found and it is a guilty under the act of the government. Then there is a strict enforcement of the Prenatal Diagnostic Technique Act 1994. So it is a very PNDT Act, which is called as a PNDT Act, and which is very strictly followed by the government offices, I mean the government services and health services. Soft loans to ensure mobility of the ANMs will be increased. So some soft loans will be given. And the 42nd institutional amendment has frozen the number of representatives in the Lok Sabha at 1971 census level, and the freeze is currently valid until 2001 and has served as an incentive for both our state government to fearlessly pursue the agenda of population stabilization and freeze the needs to be extended until 2026. So it is the uh, as per the census policy, the representative in the Lok Sabha. So it is also amendment has done. Then the summary of the national population policy. The new national population policy 2000 is a matter of fertility and the mortality rates. It also deals with the women's education, women empowerment, improvement in health and nutritional status of women, child survival and health, family welfare services, health care for the underserved population, groups like urban slum, tribal community, hill area population. So objectives is to bring the TFR down substantially. Total fertility rate, it is at present, it is 2.1, but it is a reasonably now well controlled. Long-term objective is to achieve the requirement of the suitable economic growth, social development, and environmental protection. Okay, thank you so much. So this is all for the today's session. So we have seen today the National Health Policy 1983, 2002, and 2017. In 1983, the policy was established based on the Alma-Ata Declaration, which was happened in the Alma-Ata Declaration, Russia, the USSR, and the main concept or main objective of the primary healthcare was the main objective in 1983 policy. But there are some of the lapses found in the 1983 policy. So it is revised in the 2002. And in the 2002, it is a little bit comprehensive, task oriented, target oriented, but still the target was not achieved. So again, it is revised in the 2017, and in line with the what you can say the Niti Aayog or some expenditure is increased, health expenditure is increased, more health services are improved, infrastructure is improved, manpower is improved. Okay, so in that way, the 2017 policy has made, and it is the universal coverage was the main agenda of the 2017 policy. And in the national population policy, which was in the 2000, it is established in 2000, and that also focused on the family welfare services, family planning services, distribution of the contraceptives. The small family norm concept has come up with this policy. And in that way, our healthcare system becomes strengthened. Healthcare system becomes a very, what you can say, the robust healthcare services where we are provided. Thank you so much. I will stop sharing. Mr. Alvin, are you there? Alvin? Oh, I will stop recording. Thank you so much.